So coming to a term and coming to a case scenario which we acquire daily, that is known as PDPH or meningeal puncture headache. Nowadays we are not using the term only post-dural puncture headache, we are now using the term known as meningeal puncture headache also. Thus the anatomically supported term meningeal puncture headache has been proposed as an alternative to rather ambiguous term known as PDPH. This includes the ophthalmic branch of the trigeminal nerve, cranial nerve number B1 in the frontal headache pain, cranial nerve number 9 and 10 for occipital pain, and cervical nerve C1 to C3 in neck pain and shoulder pain. So what is PDPH? Actually, when you are putting a regional blocks, the patient develop headaches in the after 48 hours to 5 days, excruciating headache in the frontal and occipital regions. It is mostly relief when the patient is having lie down position, and it is aggravated when the position is having the sitting positions. Sometimes it is also associated with diplopia. Sometimes it is also associated with neck stiffness. Sometimes it is also associated with nausea. So we call this term as a PDPH. And because the PDPH is most common in the young and obstetric patient, I am discussing PDPH here. Otherwise, it should be discussed in the regional nerve blocks. So here nausea is attributed to because of the vagal stimulations. So in the exam, suppose examiner asks what is PDPH, you have to give a proper definition. I will give you the proper definition in the subsequent slides. There may be some auditory and vestibular symptoms are secondary to the direct communication of the CSF with the perilimb by the cochlear aqueduct. Because as there is a changes in the perilimb also, or changes in the cochlear aqueduct also, there will be some amount of changes in the vestibular and auditory systems also. The International Society of Headache Society (IHS), the diagnostic criteria further describes the positional quality and worsening 15 minutes of sitting or standing and improving 15 minutes after lying down. Actually, this headache will disappear when the patient will be lying down for 15 minutes. Headache is always bilateral with the distribution of frontal, occipital or both. Headaches are typically described as dull aching, throbbing or pressure type headache. The headache may be dull aching, throbbing or pressure type. So here Indian Headache Society criteria for PDPH as follows. There is neck stiffness, tinnitus, hypoacusia, photophobia and nausea. There is no evidence to support the common practice of recommending bed rest and aggressive hydration in prevention of PDPH. So initially we will tell the bed rest and putting proper hydration will relieve PDPH, but nowadays it is observed that the patient putting on adequate hydration and bed rest, it will not cause or relieve PDPH. So IHS criteria for PDPH as follows. Headache accompanied by at least one of these symptoms. Again repeating I am this: neck stiffness, tinnitus, hypoacusia, photophobia and nausea. Okay. So major patient related risk factor for PDPH. So what are the risk factor related to PDPH? Suppose now is this NB is putting exams in 5 marks questions. So he will not directly ask for PDPH. Suppose NB will ask exam for write the risk factor, write the definition of PDPH 2 marks. So you have to read PDPH as much as all these things, like definition of PDPH, risk factor for PDPH and management of PDPH. So if the NB is asking a particular question, then you have to write a particular answer for that. Related risk factor for PDPH is, it is mostly common in the young age group. It is uncommon in patient less than 10 years of age. Peak incidence in the teens and early 20s. It is very much less common in the elderly, because in the elderly, as the ligaments are calcified, the ligamentum flavum, all these are calcified, there is highly a less chance of leak of the CSF. So in the young patient, as the dura is very much permeable, the chances of the leak of the CSF is much more possible. So in the early 20s, the chances of the PDPH is more. When you compare to gender, in the patients of pregnant females are in the more risk of developing PDPH than comparison to the males. There is no evidence to support the common practice of recommending bed rest, aggressive hydration in the prevention of PDPH. Again I am repeating, because it is not for exam sake, it is for the practice sake I am telling.